Hi everyone, my name is Dinesh Sarasena and I'm a consultant in sports and exercise medicine. Today we're going to be talking about an approach to knee and thigh pain. First and foremost, I'd like to thank the Malaysian Association of Sports Medicine and the AFSM for inviting me to give this talk. It's an honor and a privilege, and I hope that over the next 20 to 30 minutes, I will give the topic justice and you'll go away learning something new or revisiting something that you may have forgotten from past experience. Just at this point, to do a little bit of marketing, and I hope you don't mind, I have 3 resources that hopefully you will find useful in sports medicine. First of all, there's the YouTube web page that I put together, which covers a lot about musculoskeletal ultrasound and ultrasound guided interventions. It's really focused on helping clinicians who are working in sports medicine to take these lessons and then be able to apply them for their clinical practice. In addition to stuff on musculoskeletal ultrasound, there are a lot of cases that I've come across, and there's also some videos on interventions as well. Another resource that I'd like to share with you is the book that I put together on ultrasound guided interventions. Now, it doesn't cover how to scan, but it does cover all the ins and outs of what you might need to do when you're undertaking ultrasound guided interventions, particularly those relevant to sports medicine physicians. And finally, there's a multidisciplinary online resource, sportsmedinfo.sg. Now, this is something that is completely free to use. There's no subscription required, and it's basically a repository of information which is available to both your patients, yourselves, and their friends and family. It covers the core elements of a variety of different conditions, and it does provide patients and clinicians with an insight of when to refer on and what the pertinent symptoms might be for a particular problem. Please do take a look at these resources. I've put them together for everyone's use, and I am always open to hearing your feedback and thoughts about the resources and how I can improve things in the future. So let's move on to the main part of the talk, which is to cover about knee and thigh pain. To begin with, it's useful to recap a little bit about the clinical anatomy that we will be encountering when dealing with these areas of the body. In particular, I've tried to break it down into bony, muscular, ligamentous, and connective tissue, as well as the neurovascular structures. So when we're dealing with the knee and thigh pain, it's important to remember and reflect upon the anatomy from the hip downwards. So here we have images of the anterior and posterior aspects of the leg. And in particular, we're focusing on the bony anatomy. So remember, pathologies around the pelvis, around the hip joint, then we have the femoral shaft, and the knee joint can all cause symptoms around the thigh or the knee. It's also important to be familiar with the anatomy from the posterior aspect as well. That's because not only can thigh and knee pain be occurring around the anterior aspect, but also medially, laterally, and posteriorly. And hence, knowing the 3D anatomy is useful when identifying what structures may be under stress and what pathologies there may be. Let's move on to the connective tissue. Now, in this, I've included not only the ligamentous structures, but also the tendinous structures. Remember, around the joint, we have the joint capsule, which can become thickened, particularly if there's a synovitis. It can be stretched if there is an effusion in the joint. Ligamentous structures can be put under stress, particularly during times of training, competition, overloading, or sudden acute exacerbation, such as trauma. And also, not just the ligaments, but also the tendons. Now remember, the tendons are prone to tendinopathic changes with excessive load. There could be trauma to the tendons, so it could be a tear or a degenerative change within it. And so it's really important to consider what structures could be contributing. As mentioned in my previous slide, it's important when considering the thigh or knee pain to look from the hip downwards. So start around the pelvis, then the hip joint, then move along the femur down to the knee joint. And around these areas, there's a whole complexity of different anatomical structures that we must be considering, be it the collateral ligaments, the ACL or the PCL, whether it's the quadriceps or patellar tendons, the popliteus tendon. And if we're moving further up around the hip joint, it could be the hip joint itself, it could be the iliopsoas, the gluteus medius tendons, the bursa that's around it. And then if we go more medial, there's always the adductor tendons and the pubic symphysis, and all of these structures can be contributing to pain symptoms. Posteriorly, we also have other structures, so the hamstring tendons as well. And it's really important to be aware of the different anatomical structures, particularly connective tissue-wise, that could be contributing to the pain symptoms. Moving forward, we have the hip flexors, we have the proximal thigh muscles, so we have things like the pectineus, we have the sartorius, and we also have the quadriceps. Medially, we will have the adductors. Posteriorly, we will have the hamstrings, and all of these blend down into the various tendinous structures to enable movement of not just the hip, but also the knee. Now, any one of these structures could be affected by a whole multitude of different underlying pathologies, be it from the vascular supply, be it from trauma, could be from overload and insufficient time for recovery. And so it's really important when you're assessing the thigh and the knee area to be aware of the muscular structures that play a pivotal role in the movement and stability around the lower limb. And if you aren't aware of these things, it makes it very hard to come up with a reasonable differential diagnosis. Another area to consider are the neurovascular structures. In the thigh, it may be something like a neuralgia paresthetica, which is contributing to the pain symptoms. Perhaps there has been a tear of the muscle, and as a consequence, there's a hematoma, which is compressing the nerve. Perhaps the hamstrings and the sciatic nerve has got irritated, and it's causing shooting pain along the back of the leg, down to the knee and below. So it's really important when you're assessing the leg to also consider the neural structures. And sometimes it's important as well, not just to think about where the problem is, but where it could be coming from. In this sense, it's important also to check for nerve tension. And sometimes it could be the femoral nerve or the sciatic nerve that you're assessing and is also contributing to the pain symptoms. Vascular structures are also important, and often is the case you need to be checking for proximal as well as peripheral pulses. In the case of pain around the knee, could it be from a vascular structure such as a popliteal artery entrapment or a popliteal aneurysm? So again, checking for these, checking the pulses, listening for bruits, and being aware of the key vascular structures in and around the thigh and the knee are very, very important. So now let's move on to assessing this area a little bit more from a clinical context. Let's look at the history and identify what are the key factors that we need to be thinking about. First of all, was there a mechanism of injury that caused trauma and led to the symptoms, which is now what the patient is presenting with? What was the progression of the disease or injury? Was there any history of a past similar injury that could be a significant risk factor to them developing it again? This is particularly prevalent with the thigh and muscle strain. So if somebody has had a muscle tear in the past, they're at higher risk of developing it again in the future. And then what I often ask patients is, what's happening now? Sometimes there can be a delay from the initial presentation to them presenting to you in clinic. And so what are the main symptoms now? Well, tell me more about your pain. What are the functional limitations that have been imposed upon you as a consequence of this injury? And then lastly, we must never forget about red flag symptoms. This is really important. So if somebody has bilateral lower limb symptoms, always consider the spine and always look out for red flag symptoms prior to moving on to further assessments. So let's have a look at the mechanism. Now, of course, some of the mechanisms that I have here on the image are ridiculous. However, it's really important to have a good grasp of what happened and how the patient was affected. Were they able to carry on with sport at that time? Was there any external forces involved? In fact, some patients can have footage, say they were playing in a match and somebody was recording, and it's very useful to be able to watch that footage and understand further what exactly happened. Your next area of assessment is when the patient walks into the room. So let's have a look at this video and see the gait of this individual patient. Sometimes people ask me why I ask patients to walk into the room. And the reason for that is because my assessment of that patient begins the moment they stand up and start walking in. If you look at this video here, you can see this patient has a Trendelenburg gait, so one side of the hip drops. Now, if, let's say, you hadn't called the patient in, it might be a vital clue that you miss. So always start your assessment as soon as the patient stands up to walk in and be observant of how they're doing so. The next thing with observation is to have a look at how they're standing. Now, particularly with a thigh or knee problem, they may be offloading one side. There may be pathology elsewhere, which may be affecting their standing posture. So they may be swaying back. They may be standing to one side. They may be having a more lordotic position, particularly if they've got hip flexor tightness. So it's important while we're looking at the thigh and the knee to also have a look at their overall standing posture and how the pathology may be affecting this. Now, as I mentioned, the assessment should begin when the patient's walking in. But if you haven't perhaps picked up on the Trendelenburg gait, you might want to have a look at see how they are when they're standing on one leg. Because essentially, this is what they're going to be having to do when they're walking and running. So having a look for the Trendelenburg sign is useful, and asking them to just to stand on one leg to see how the weight is balanced and whether the pelvis position is maintained. The next thing you can ask them to do is some functional movements. So doing a double leg squat, looking at the alignment of the upper body versus the lower body, as well as the movement of the knees into a valgus or varus position. Progressing with the functional screening, after doing the double leg squats, you can move on to single leg squats. So first of all, you're assessing for the Trendelenburg. Then you're asking the patient to do a single leg squat, so dropping on the supporting side to look for whether the knee is drifting in or out. And also you want to see how the upper body compensates to maintain the position. Having done the functional movements, we then can progress to movements of the particular areas. And because we're dealing with the thigh as well as the knee, it's important to start at the hip. With the hip, remember, you don't just have flexion and extension movements, you also have abduction, adduction, and internal and external rotation. In the knee, you also have these movements, although the abduction, adduction, internal and external rotation will be to a lesser extent than you have at the hip. Moving forward, we move on to palpation. Now, palpation obviously depends on the anatomy you're concerned about, but also it depends on how well you know the anatomy when you are pressing around the hip. There's various ways of doing it, and it doesn't really matter whether you start from proximal to distal, medial to lateral, anterior to posterior. But the key thing is having a system in mind, being mindful of the anatomy when you are palpating it, and then, even calling it out in your head when you are doing so you don't miss anything. Here is a sequence of structures that you may want to palpate when you're undertaking a hip assessment. And in this situation, it might be useful to start with the anterior and then flip the patient over and do a posterior palpation. It's less essential to get it in the same order, but it's more essential to make sure you've covered all the anatomy. Similarly, with the knee, and when you're palpating around the knee, it's important to have a system in mind. Again, it doesn't matter whether you start from proximal to distal, medial to lateral, or posterior to anterior, but what the key thing is to palpate all the anatomy appropriately, and again, call out in your head what you might be palpating, and then finally making sure that you've got a system in place so that you don't miss any of the important structures. Then we have the tests. In the various areas that we do examine in sports medicine, there's a whole plethora of different clinical tests that we can use. What's really important is not necessarily doing all of them in one go, but it's picking the ones that are right for you and the patient and the presentation that they've come in with. So it may not be appropriate necessarily to do Fabers or Feder's for a presentation, but if the patient has come in with pain around the adductors, then of course doing squeeze tests and palpating around the pubic symphysis will be super important. Similarly, around the knee, there may be some tests which are more relevant to the clinical presentation than others. Different to the hip, however, is one may be injured in succession to the other, and therefore it sometimes is important to go through as many tests as possible to identify which structures have been injured and which may require further treatment. When it comes to examining the thigh, remember there are predominantly muscular and neurovascular structures running through this area. When it comes to the muscular structures, it may be that you are concerned about a muscle tear or hematoma, in which case you may be looking for deficits or lumps or bumps in the muscular structures. For the neurovascular structures, it may be important to do peripheral tests, so looking for pulses, looking for capillary refill, and so on. When it comes to the tests, however, the majority will focus on things like the neurovascular structures. So in particular, doing the straight leg raise for a sciatic nerve lesion or the femoral stretch for a femoral nerve pathology. In terms of the muscular structures, there may be tests that you do elsewhere to assess for the muscles. So maybe a muscle stretch test, such as Ober's, or you may do something like the modified Thomas test to look for muscle tightness in the hip flexors, quads, or ITB. So that was a bit of a crash course in the clinical assessment. But always remember that even though you're dealing with the lower limb, particularly around the thigh and the knee, it's important to assess the hip, and it's imperative as well that you assess for the lumbar spine, particularly if the patient has symptoms that are somewhat unusual or bilateral symptoms that may be neural in nature. Okay, so let's move on to some pathologies or common problems that you may encounter. For this, I'm going to focus on those around the hip, the thigh, and the knee. Now, hip and groin problems can be quite complex, particularly because there's often an overlap with the lumbar spine. There can be radiation into the leg, and because of the complexity of the structures around it. And so it's useful to try and divide it into anterior, lateral, and posterior. If we look at the posterior aspect of the thigh, one problem that we can encounter is piriformis syndrome. Now, this could be due to compression prolonged around the piriformis. It could be due to hypertrophy of the muscle itself, and sometimes this may cause irritation of the sciatic nerve. This is particularly prevalent if the nerve passes through the piriformis, which is an anatomical variation, or if it's getting compressed due to the thickening or hypertrophy of this muscle. Sometimes it can mimic sciatica, and in this situation, it's important to palpate around the piriformis to see if it causes the pain to radiate down the leg. Also, examine the lumbar spine to identify if there's any lumbar spine pathologies. But remember, in situations where there has been nerve irritation due to lumbar spine, the sciatic nerve may be sensitized. And even when you palpate around the piriformis, it may cause some symptoms. It's useful to go back to your history and determine, is there a pathology in the lumbar spine? Is it focused more around the pelvis, or where you feel that this problem is originating from, based on history, and then corroborating it with your examination? Other causes of pain around the hip and pelvic area could be due to gluteus pathologies, so gluteus medius tendinopathies. It could be due to hamstring origin pathologies, ischial bursitis. And so there's this whole multitude of different things that could cause pain around the hip, but also that could radiate into the thigh and even sometimes down to the knee. Being mindful of the anatomical structures that can be affected is therefore pivotal when you're examining and assessing the posterior aspect of the hip. One of the other areas to consider when examining the posterior aspect of the hip is the lumbar spine, but particularly relevant to the lower legs is the sacroiliac joint. Now, the sacroiliac joint can be irritated. There could be inflammation. There could be an inflammatory process that's going on there, or it could be that there's some degree of instability. And as a consequence, when the sacroiliac joint's irritated, you can get weakness in the leg, you can get pain radiating into the back of the leg, and it can stop around the knee. So assessing the sacroiliac joint when you're assessing the hip is very important, particularly if a patient comes in with posterior thigh pain. If we look at the lateral aspect of the hip, there are some common problems that we may encounter as well. It could be a trochanteric bursitis, a gluteus medius tendinopathy, or a problem with the iliotibial band. Quite often, there can be a significant overlap with these problems, and so it may not be one in isolation. In this situation, it sometimes is important to do localized and focused treatments for different structures to identify which one is the root cause and which one is the consequence of that problem. Then we move on to the anterior aspect. And again, same with the posterior and lateral aspect of the thigh. There are a whole multitude of different pathologies that could be going on in isolation or concurrently with a significant overlap of the symptoms. Things to consider here are the muscles at the front, so things like the obliques, the rectus abdominis, the adductors, and the hip flexors, the ligaments such as the inguinal ligament, the conjoint ligament, and also the pubic symphysis. It could be a tendinopathy of any of the muscular structures at the bony attachments, but there are other things as well, such as the hip joint or the femoral nerve. So all of these can have a significant and complex interplay, which all can be contributing to the anterior hip pain. If you're worried about the hip flexors, quite often in cyclists, because they are in a prolonged forward-leaning posture, they may have hip flexor tightness. Now, this may not present necessarily with anterior hip pain, but it could present with lower back pain instead. It could also be because they spend several hours in the riding position, they develop not just hip flexor tightness, but quadriceps tightness as well. In this situation, identifying which one has come first and which one is the consequence, again, is important when you're dealing with thigh and knee pain. Another cause of hip flexor tightness, other than cycling, is sitting. And with many people doing office-based occupations, and with the change in the working and living environments during COVID, it could be that people develop hip flexor tightness from doing this as opposed to doing it with regard to any sport. There's been many patients who haven't had any trauma or sports related issues, but from working from home, they develop back pain symptoms. And so trying to identify how and when the symptoms arose is very, very important. Adductor pain or pubic symphysis pain is also very common. It could be due to poor trunk control. And one of the ways that we can look for it is by palpating over the pubic symphysis to see if there's any pain around this, or doing things like the squeeze test at the various different positions of the lower limb to see if it's causing the symptom. If you do identify there to be an adductor problem, it's important to look into this further to see if it's a tendinopathy or whether it's a degenerative problem due to load over a period of time. Around the hip joint itself, pain could be due to hip impingement, and in that situation, you're looking for a CAM or a pincer lesion, which may be causing the anterior aspect of the hip joint to catch with flexion and internal rotation and adduction. And if this is the case, you may also be concerned about a labral pathology happening concurrently. In the older patient, you may be wondering, is this actually hip impingement or is this a degenerative process going on in the hip? And so as patients get older and they want to maintain their level of sporting activities, our pathologies that we consider would also need to change accordingly. Typically, with degenerative changes in the hip, the patient may present with the C sign. And that's where they press their hand around the hip joint and say, this is where my location of pain is. It's a classic sign that goes with degenerative changes in the hip. Let's move to thinking about the knee now. So again, around the knee, there's a whole host of different problems that could be there. And it's useful to start to identify it according to the area of the knee that may be affected. Looking at the anterior structures, there's a plethora of different things, ranging from tendinopathies to cartilage issues to ligament problems and meniscus. Around the medial and lateral aspects, again, there's meniscus issues as well as ligament problems. And around the posterior aspect of the knee, this sometimes is a little bit more forgotten unless there's significant symptoms. But it's really, really important that you assess for things like the hamstrings and palpate around the posterior joint line, not just for things like Baker's cyst, but also for posterior horns of the meniscus as well. So looking at some common problems around the knee, we have runner's knee, which is essentially a pathology affecting the cartilage behind the patella. Often patients will have sharp pain, particularly with a eccentric load being applied. There may be instability of the knee associated with the pain. And this is where asking them about functional issues is very important. Whether they have pain going up and down the stairs, whether they have pain with squatting, and then having a look to see if there's any muscle imbalance issues, which may be causing the patella to be drifting medial or laterally, depending on which side is more dominant. Around the front of the knee as well, to go with it, we have things like Sinding-Larsen-Johansson disease or Osgood-Schlatter's, which is essentially an overload of the patellar tendon at different ends. In this situation, it's important to go back to the history as well and look at the training load that the athlete may be putting themselves through, looking for any rest periods, and then identifying what can be done in terms of offloading that tendon and hopefully reducing the impact training has on it. If it's not adhered to, it may eventually lead to tendinopathic issues with calcifications further down the line. And as a consequence, it becomes much more challenging to treat. In the knee as well, we have ligament problems. So here we have the ACL tear, typically happening when the foot's planted and the knee's twisted. Patients complain of a popping sensation in the knee. There's usually swelling, instability. There can be locking as well. And in situations where you have the meniscus tear as well as the MCL, you have O'Donoghue's triad, or there could be tibial plateau fractures as well. Now, all of these can be happening simultaneously. And so going back to identifying what the mechanism of injury, the progression of symptoms were, is really important to identify how much this is going to be affecting the individual. In keeping with pathologies in the knee, let's consider the meniscus as well. Quite often, the trauma to a meniscus can be quite innocuous, and it could be an acute or degenerative process that's underlying. Often, patients may report instability, swelling, locking to the knee, and sometimes issues with going up and down stairs. Again, it's important to try and really delve down into the history to identify what could have happened. and how it's affecting them as well. Assessing them clinically with McMurray's or Thessaly's test can be helpful in identifying which side of the meniscus has been injured and the degree. If there is inability to flex and extend the knee, it could be a much more profound meniscal tear than otherwise. So dealing with the thigh, there's a whole variety of different structures that could be injured, but commonly it's the musculature, neurovascular structures, or the bony structures. Let's think about hamstring injuries. Now remember, there are three hamstring muscles: the semimembranosus, semitendinosus, both medially, and the biceps femoris laterally. Most commonly, the biceps femoris is affected through eccentric loading, particularly in fast movements such as sprinting during a race, or maybe with soccer. There will be a sudden pain in the back of the thigh and sudden inability to walk and weight bear. Depending on the degree of the injury, there can be significant swelling, bruising, and also loss of function. If you can imagine, around the posterior aspect of the thigh, there's all of this happening. It's inevitable that the nerve is also going to be affected badly, and you can get pseudosciatica symptoms. Around the front of the thigh, it could be, again, a muscular injury. More recently, I've had a number of footballers coming in with rectus femoris injuries. Now, this is typically when the muscle is being eccentrically loaded, such as when they're kicking the ball or when they are blocking a shot, and the muscle is contracting but also being stretched at the same time. The rectus femoris can be affected at either side, from the muscular tendinous junction proximally down to the quadriceps tendon distally. The location and the degree of injury varies considerably, but what we do know is that a previous injury is a high risk for further injury in the future. And then you can get other nerve problems in the thigh, such as myalgia parestetica, where there's been compression of the lateral femoral cutaneous nerve, either from an increase in weight or tight garments, and this causes burning, tingling, numbness, and pain around the anterolateral aspect of the thigh. Similarly, around the posterior aspect, it could be from the piriformis compressing the sciatic nerve around the hip, or it could be related to SI joint or sacroiliac joint problems that are causing a pseudo sciatica and causing the pain to radiate down the legs. It's therefore really important to try and identify where the origin of the pain is by working backwards, using your history and clinical acumen when assessing the patient. So having dealt with the hip, thigh, and knee common problems, let's have a look at some broad principles quickly in terms of management. So this is how I look at it. First and foremost, offload the area. Next, we want appropriate investigation and focused treatment. Next, we want early rehabilitation. There needs to be a graduated return to sport. And then finally, we want to try and put in some preventative strategies as well. In terms of offloading, it depends on which area of the body is affected. Of course, with the lower limb, it may be using crutches or a boot to not only offload, but also immobilize the area. Next, it's the investigation. For many of us working in sports medicine, we may have access to musculoskeletal ultrasound, and this often forms the first line of investigation. However, we should have a low threshold for corroborating this with other investigative modalities. This could be CT if we're considering a bony pathology, or an MRI scan if we're considering bony as well as soft tissue. Having identified what the problem is, you may want to consider some focused treatments to complement the subsequent rehabilitation. Now, this could be as simple as analgesia, or it could go further through things like PRP, hyaluronic acid injections, or things like Tenex, or even surgical interventions. Depending on what the pathology is, depending on the individual, and depending on what sport they may be doing and when their next event may be, you may want to put in additional interventions early rather than wait and just give a conservative approach to the treatment. Early rehabilitation is important. And the reason for this is not only are we trying to help the patient recover from the injury, but we're also trying to minimize any further or subsequent issues, whether it's related to muscle atrophy, joint stiffness, instability, and so on. And then we move on to a graduated return to sport. Often is the case that the expectation will be that having had intervention and rehabilitation, that patients can go straight back to their previous level of sport. But we know that this is often not the case, and there needs to be a progressive traffic light system in terms of returning to their sport so that they're able to do so safely and successfully without risk of further injury. Indeed, the last section of management is to try and minimize the recurrence of the symptom. And that's firstly by taking the patient through an effective recovery and rehabilitation, but also identifying what could be the underlying risk factors and trying to deal with this as well. Back in 1992, Van Mechelen put together an excellent flowchart, which I still believe has significant relevance to us today, and demonstrates the importance of sports physicians and other healthcare professionals working in sports of identifying what the risk factors are and how we can try and minimize risk of injury for that individual as well as others. Thanks for watching. I am again grateful to the Malaysian Association of Sports Medicine and the Asian Federation of Sports Medicine for inviting me to give this talk and to be involved in the upcoming conference. And I look forward to meeting you, the delegates, in Kota Kinabalu in April.